over the years is the one thing that really changes executive behavior, and I think that's really what we're talking about here is
Mhm.
change executive behavior. The one thing that really works to do that is to go to a site that's better than your place.
Mm.
And if you can get at least one of your executives to go see this stuff, it will change their mind. And
So
I actually,
welcome to this week's episode of Leadership Soundbites with my super special guest, Dr. John Toussaint. So John is the executive chairman of Catalysis, and Catalysis is a not-for-profit organization that supports healthcare leaders around the world in their organizational excellence journeys. And it is, I'm blessed to be faculty of Catalysis. I first connected with Catalysis when I worked at Sutter Health. So I was the central point of contact for Catalysis and the work that they're doing. It's important frickin' work. So unlike you'll have industries that literally the improvement work they do saves lives, but not so much as in this space where this work is being done. And so thank you, sir, for joining the conversation. I know you've got a quote that you kind of go back to, and if you can kick us off with that, and then we'll chat.
sure, thanks, Michelle. Yeah, I really um, sort of when I think about what we want in terms of the world, I go back to Mahatma Gandhi, basically, who said, "Be the change you want to see in the world."
Um, it's interesting because I know you led the journey, or you and Kim did at Theta Care, of the improvement work that was done there. And I know what happens with all of us, or a great percentage of us can do, is we look forward to stuff and go, okay, it's not currently being done. And our subconscious could say something at the level, it's not possible. And I think it's important when you talk about that quote, is to be the change that you want to see in the world. Is just because you don't see it, how it could be, or the best that it could be, doesn't mean it's not possible. And that story, and I'm holding the book up, oh, maybe you can see a little bit. Every Patient Counts. It's the latest book, and it's around that journey of be the change that you want to see in the world with healthcare in South Africa. And so I would love it if you could just share a little bit about that, the real side of it, and then I'll step in too, because like I told you, I'm 83 pages in of 109, I think, of narrative in the book. And it's a really cool frickin' story.
Yeah, it is. I think the the key is the commitment and persistence of the basically the two leaders that we showcase in the book, and uh, Mr. Gray Dubé in Laertong Hospital in Johannesburg, which is right in the middle of one of the worst slums I've ever seen. Uh, he was very frustrated with all of the years that he had been in executive leadership in public hospitals in South Africa. And so he had the chance, as well as Gladys Bogashi, who's the other person that we highlight in the book, to come to the US and actually visit Theta Care. And after that visit, they went back and changed the cultures of their two hospital systems. And in so doing, dramatically improved the mortality rates, saved 75 babies a year, or saved 30 mothers a year. I mean, it's amazing what they did with basically no resources. I mean, I
Mhm.
was on the phone with them once a month. Kim or I was on the phone once a month for 12 months. And we went and visited once. And it's one of the best examples of, you know, creating excellence in everything you do of any place in the world today, and it's still going on. So it just goes to show you you can do this if you commit to it, if you're persistent, and if you kind of have a vision of where you want your organization to be,
Mhm.
going from where it is to where you want it to be. And part of that becoming the change is, you know, really the change that you want to see in your organization. And both those leaders made dramatic changes in their behaviors and actions to
Mhm.
those results.
Well, and so like you and I were chatting, what I commented before I hit record is that um they saw that it was possible. So their vision, when they came to visit at Theta Care, they saw what better looked like. They saw what it took. And I agree with you. They're going back, and you highlight it in the book. The changes that they had to do in leadership is similar to other from traditional leadership, to where I got promoted, I'm the answer person, I've got everything. Basically, I wear the cape, I'm going to solve the problems. And by the way, that's a daunting responsibility for leaders. And when we have leaders that are in that position that actually believe that they have to have all the answers, they're human. And so that's why I coach leaders. And it's like, okay, you can't possibly know all the stuff, but the combo of the people, you and the people on your team, that combination is powerful. And that's what we do when we tap into that culture shift and tapping in at all levels. And it requires leaders to be vulnerable and step in with curiosity, which you highlight in the book, to say, you know what, let me go seek to understand what's really happening. Let me hear what people are saying on the front lines. And that was a dramatic shift from before. I mean, one of their contributors to infection was absenteeism. Well, people weren't absent. You think in the US, well, people are calling out, they're doing all that stuff. Yeah, because maybe they don't care. I've had leaders tell me in the US side of it that people are on performance reviews for absenteeism, calling out, and then they just get written up for it. And then they come back and ask the leader, well, can I call out again? That wasn't what was going on in South Africa.
No, it actually, the problem was that these staff members, they lived in some of these, kind of situations, and they didn't have anyone to take care of their kids when they got sick during the day. And the Laertong policy was you can't just come to work 4 hours, you have to come to work 8 hours or 10 hours, or you can't come to work. Well, the reality was that many of these nurses could get to work at noon, but not at 8 a.m. But since the policy was, if you can't get there for the full shift, you can't come. And that's when the manager started to, try to unpack why people were missing work. She realized that, wow, it's our policy that's causing the problem, right? It's the leaders' problem that are causing the problem. So once they got to the bottom of that problem, they understood the root cause, they changed the policy. And all of a
Mm-hmm.
sudden, absentee rates, because they were able to then manage the staffing, so if somebody's going to be gone for 4 hours, they could manage the staffing, in a different way. And so they got fully staffed. But isn't it
Mm-hmm.
interesting that many of these problems we create ourselves as leaders? And so if we don't really sit down and ask the people, what they think the problem really is, we don't come up with the right answer. And that was a perfect case in point of using lean thinking to really get to the root cause of the absenteeism issue.
Yeah. Well, and my brain went when I was reading it to like, okay, there's a downside impact to the employee who, by the way, to your point, is living in these conditions. They're not getting paid. So I don't know we have a luxury in the US with PTO of people that work for healthcare organizations. It's pretty nice. I mean, they're good benefits. I don't know that that's the case in South Africa. So, it could be a situation, if you don't come to work, you don't get paid. And if you're already living paycheck to paycheck, and then you're having to call out a full day, that's a big deal.
Very big deal. And the kinds of barriers that this leadership team had, are just, I mean, you can't even imagine in our world here what those folks had to do to actually change that culture.
Mm-hmm.
And, we heard over and over, well, now Mr. Dubé is coming out, the CEO is coming out to scold us, to tell us what to do. And then when he actually asks questions, when he actually wanted to understand what the problems were, wanted to understand what he needed to do in order to support them, everything began to change. And so that
Mhm.
behavior on his part of going to the Gemba and actually trying to understand the problems his staff were facing was a big part of the turnaround.
Mm-hmm. It was interesting, one of the sections to where, I don't know, regional, some government agency that had oversight that do their tours, that basically it was a time for them that they did not like, because they got there and they heard all the stuff and all the complaints and all the everything. And this was, I don't know how far into the journey that they were on, but they didn't hear that stuff from these hospitals that were on their improvement journey and the culture change. They heard engagement and praise and things are working, and it was shocking for them. So it got the attention.
Yeah, it sure did. And actually, they got a lot of positive feedback from patients, which usually, and this was the premier of the province, the Toussaint province, one of the, which is where Johannesburg is in, the Toussaint province. And, usually if they talk to patients in these hospitals, they were complaining, waiting, everything else. But at Laretong, they were actually very satisfied. And so they walked away, he and the health executive walked away basically saying, this is amazing. We need to
Mhm.
figure out how to bring it to other hospitals in our province. And so they did. They actually hired Mr. Dubé once he stepped down to teach other leaders these principles. And I think he taught in 12 different hospitals in the province, Johannesburg area. So yeah, I mean, it works. It's hard, but the amazing thing about this story is I've never seen more difficult barriers to overcome than
Mhm.
the ones that these folks faced, but they overcame them
Mhm.
in flying colors.
Well, and I think part of it, what stood out, because we have a number of stakeholders in any culture change, and I know healthcare, for California, so I live in California, is we don't employ our docs directly. So the physicians are not employed by the healthcare organization. There's layers and buffers in between, right? So they're employed by a medical group, and then there's the foundation between the acute care hospital or the system and that. And so you've got these several layers of removal to try and exert influence. And physicians are primary, and you know this, you are one, primary drivers of what gets utilized in a healthcare system. They're writing orders, they're doing all this stuff. And so it's super important that we speak to what matters to physicians to get them on board. The same thing happened in South Africa. And I know that they went to them and said, hey, what is it going to take? Well, we need this, this, and this. And it was equipment that they needed to provide better care to their patients. And the story said, basically they were able to get that stuff. And then you had the docs that actually felt heard. And then they were on board and coming into it too.
Yeah, I mean, the physicians are a unique part of the system because that's where the value is created, is what they do. The problem is they don't understand what's, you know, before and what's after their one value creating activity, whether it's surgery or, direct conversation with patients related to diagnoses, whatever. And so you do have to, I mean, we have multiple stakeholders,
Mhm.
we think with a patient as our customer, but the reality is we have multiple customers because you can't get the work done without this team of people that include
Mhm.
physicians and nurses and technicians and others. So you really have to step back and say, what's in it for them, right? And that's what
Mhm.
Mr. Dubé did. He stepped back and said, okay, what's in it for the doctors to actually participate in this improvement activity? And so he, figured out what it was that they needed, and he got it for them, and
Mhm.
changed things that they needed to have changed. So then they came back for more and they said, okay, well, you're listening to me now. I'm willing to listen to you now to ask,
Mhm.
tell me what it is that you want to do, what you want to work on. And of course, the biggest issue was that they could never get the clinic to start on time. The doctors would show up at noon for 8 a.m. appointments. And so one of the managers, who was a doctor actually, basically said, well, listen, folks, I understand why you show up late because we never get the labs done. We never get all of these things done. And so that's why the patients are late. That's why you're showing up late. You're doing your rounds, whatever. And then when they fixed those processes and the patients started showing up on time, the docs were still showing up late. And so what she did, and guilty as charged, I've done the same thing, is she actually unblinded the physician's on-time performance. So each doctor saw who was late to the clinic. And within a couple months, the clinic was starting on time.
Yeah.
But the point is that they had fixed the processes so that everything the doctor needed to see the patient, whether it was the lab work, whether it was, getting the chart, whatever, that was all, done in the time that it was supposed to be done. So you couldn't completely blame the doctors because the processes were horrible. So they fixed the processes. Then we had to get the doctors on board, and one of the ways to do that is to create a little competition. What they did, and the doctors complied. They love to compete, right? We're very competitive people.
Yeah.
So that worked, so there's a little mix of, improvement thinking, sort of the social technical side of things, right? Little competition, little this, little that, and it's all of a sudden it's the magic stew that begins to really deliver pretty amazing results.
It's so funny. You take me back to a couple things. One of them, I was a lean consultant and then senior lean consultant in Sutter Health at one point in my career. And we were doing work in surgical services. And it was chief of surgery, whatever the lead surgeon is within that group. And I apologize for not knowing the actual title. Super cool guy, very direct, very direct. And he was the champion for the work that we were doing in surgical services. And so we had done a 5S, improvement event, and improving processes on turnover times for the rooms so that we could improve that in surgery in the OR. And so we had seen some wins in this stuff. And because of that, he was engaged. So we were having a meeting between the director of surgery and we're waiting for him. And I was there with, I think, one other person on my team. And I'm like, where's Dr. So-and-so? Oh, he's in surgery right now. So he had some patient with something in their throat or something, right? Something stuck. And we're like, okay, so we proceed. We start to the meeting, and about 5 to 10 minutes in, he comes in, big guy, comes in and sits back in the chair. He goes, okay, what did I miss? And I'm like, I thought you were in surgery. He goes, I know, I got that done. I just had to be here. So you've got a surgeon who was like wrapping stuff up so he could be part of this work still and part of the meeting for the updates because he was so excited about the basic changes that we made that were radically improving his life and his experience. So it's possible. And it's cool to see. And once you have that, I tell people you have momentum that will eventually lead to traction. But you have to first get the flywheel spinning, right? Before it keeps going. But it's possible.
The doctors get blamed, but in reality, it's our fault as the leaders not engaging them in work that's actually going to make their life better. And I think that's the key take-home message is what's in it for them. Figure that out. Let's go get it.
Yeah. No, I just I totally agree with you, and I think it's exciting. And so for me, it's bridging the gap from the stuff that we've seen, that we've experienced, where we are now, because you're still in it, you're still with Catalysis, you're still doing the work. So John, what stands out for you that the opportunity that we have to be able to step in and actually broaden the amount of impact that we had? It's almost like, what do we need to do differently? Or maybe we're doing it and just not enough of it.
I think that what I've learned over the years is the one thing that really changes executive behavior, and I think that's really what we're talking about here is change executive behavior. The one thing that really works to do that is to go to a site that's better than your place. see those systems and behaviors in action. And so that's why we have created at Catalysis a number of site visits that you can go see what good looks like at UMass Memorial or Ohio Health or Zuckerberg San Francisco General or One Clinic. We have different site visit opportunities. And if you can get at least one of your executives to go see this stuff, it will change their mind. And I actually kept track of that when we had thousands of visitors when I was CEO of ThedaCare. We actually kept track. I would say about 80% of the time, which is pretty good, 80-20, we changed somebody's mindset. We changed their behavior. And we know that because when we followed up with them, we found out what they did. And they actually did things. So I think unless we can get more executives to come to these places that have really gotten good at this method, we're not going to change much. So that's why we're making a big push to get site visits going again at good places and to facilitate that learning system.
Yeah.
You know, it's just like the folks in Africa. Once they saw it, it's like that I want it. And so they were willing to put out a lot of personal energy and stuff to make it happen.
There's a couple things. I was at one of the Catalysis summits, and I don't know how many years back it was. But there was a board that was that was speaking from one of the healthcare organizations. It may have been in the UK. That they taught, or Canada, but they talked about their own board journey in lean management system. And it reminded me, John, because you touched on it in the book here around the board at ThedaCare. And I walked away because I was at Sutter Health at the time. And I walked away going, this is the missing link. Okay. Is that in order to have continuity and not have the next leadership unpack what the gains that the organization has made, the people that are interviewing the next leader needs to be on board and need to be able to understand. Can you say more about that and maybe how, are you seeing that there's an intentionality around that, or is that still a pretty good gap?
The big gap. And in fact, some of the best organizations around the world still struggle with this significantly. And when I go to Gemba, I've been to 271 different health systems in 20 countries. So I go to Gemba a lot, and I almost never see what you saw at that meeting. And there were a couple organizations, St. Charles and Bend, Oregon, had very, very strong board leadership on this, and then St. Mary's in Ontario. But most of the time, we don't see that level of, I would say, understanding. And so what we've tried to do at Catalysis is to encourage the CEO or the leadership team to get the board involved in understanding the methodology by practicing it. And believe it or not, you can practice this method at your work of governance. And so once you begin to practice the method, then you understand it, so that when it comes time for succession, this is something that you look for. I sit on a board of a company right now, and that's going through a succession process. And the number one priority of the CEO is to maintain the culture of continuous improvement that he's built over the last 15 years. And so we've been through several different candidates that basically don't meet the criteria, which is really a deep understanding of the improvement methodology that we espouse. And so I think if there's that level of commitment at the board, then you're going to end up with a good outcome. So what we've designed like an 18-month to 2-year process where we can get boards on board, so to speak.
Yeah.
In terms of understanding this, and we take it in not huge bites, small bites, so that they get acclimated to the methodology. And we think over a couple of year period, you can actually get your board to have a depth of understanding of why this these particular attributes and this particular set of systems are so critical to long-term success.
Yeah. And it's interesting too, because in my head is like, most board members, it's not their full-time job. So, you're asking people to get exposed to something and think differently. So the runway is a little bit different than maybe the individual who's developing themselves to go through. But it's so critical because I've seen and heard of things unwinding because that wasn't put in place. And it's a shame. The other thing that I'll say too, and it's not around the board, but around the docs, is when I was at Sutter Health, I was in finance at one point before I went into process improvement. It's like with any organization, if it's large enough, you can switch careers and not have to leave the org. And that was the case at Sutter. So I was in finance director at one of the hospitals at one point, and then went into lean process improvement, leadership development. Margie Hagany was my mentor for A3 Thinking, the 2-day workshop. So she developed myself and Rocco Miles. And so I say that because I had this experience in different aspects of the organization that not everyone does. And so what I realized when I got into the learning and development space is we had a pretty big gap in people not actually understanding the business model of business of healthcare. And so I developed a virtual training to be able to help to close that gap. So people understood it's not like going to the supermarket and eggs are what, $9 a dozen now, but it's $6.50. It would be like going to the supermarket and going, oh, you've got them marked at $10. I'll give you $1.50 because that's healthcare. I mean, we're negotiating these contracts, right? Or if it's a government payer that comes out for the eggs, and they're going to go, okay, I'm going to give you whatever. Oh, the cost of these eggs is $1. I'm going to give you 50 cents. Because that's government payers for the most part. And for the majority of it, people don't understand the business model, that it's almost like insurance companies, that there's a risk pool, if you will. You've got commercial payers that actually cover costs with a little bit of buffer and margin in there. And then you've got other payers that don't cover cost. And so it's important for providers and people that are on the front line, I'm going to say caregivers, because nurses in the room, MAs, your LVNs, your all the people, right, to understand why we're not going to take a stack of sterile supplies and bring it into this room just for convenience, to where when the patient discharges, we throw all that stuff away because there's a cost to it. So once we start getting people understanding this is a business, even though it's not for profit, which a lot of healthcare organizations are not for profit, Sutter is, it doesn't mean that you don't make money. It means that you need to make money. It's just that your shareholders are the community with which you live in and the care that you're providing. And that shift is powerfully important. I had one physician leader that was in the room in the class one time, virtual, and I was talking to her about Medicare and Medicaid, Medi-Cal, if you will, in California, that we lose money. I mean, we below cost reimbursement. She says to the room, but I thought Medicare paid better. And I said, okay, within context, it's a true statement. Medicare pays better than Medicaid. However, we still lose money on that population. And she said, oh my gosh, I had no idea. She's not alone in that. Part of the other part too, John, is to educate people around the business model that exists with healthcare so people can understand that it's not a money tree, that you've got finite resources, and how do we make sure that they go farther? So I'll get off my soapbox.
Yeah, well, the payment system is a big part of the problem. So I've been doing a lot of work on public policy activity related to payment because I think fee for service is a mistake. It doesn't allow you to get up front of health conditions. Everybody complains about we're not keeping people healthy. Well, we're not incented to keep people healthy. So we got to figure out a way to keep people healthy. And the way to do it is to pay up front to try to keep them healthy. And so we've published several articles on this and working with various groups around the country to try to move the ball a little bit. The Purchasers Business Group on Health, which used to be called the Pacific Business Group on Health, is running some fascinating experiments around the country on really looking at different payment models.
Mhm.
And I think that we're gonna see some changes now. We haven't seen that much change, but until we start paying for health instead of paying for sickness,
Mm.
continue to have the system that we have.
Mhm. Yeah, thank you. I appreciate this time, sir. I really, truly do. Thank you. So, in the last few minutes, a question I have for you is what one or two things would you love people to walk away with around what we've been chatting about today?
Yeah, I mean, I think there's a couple things. Really, there's one thing, it's leadership. And the question is, what are you going to do to improve your leadership skills?
Mm.
So I think that's always a question in my mind of that I ask leaders. Because if you have too much hubris to say, I know everything, then it's unlikely you're going to actually build an improvement culture. Because improvement's all about getting to a certain level and then, you know, going to the next level and going to the next level and going to the next level. So that's the question I think for folks is, you know, how are you going to improve your leadership skills? And I think the other thing is that there's no question that continuous improvement is the key to improving care outcomes for patients. And that's been shown. The UC Berkeley team has done a lot of great research showing that organizations that are committed to continuous improvement perform way better than organizations that aren't. So the question is, you know, how are you going to become an expert at continuous improvement? And I think the only way you can is to, first of all, go to places that really do this well and understand the systems and the behaviors that are required to build that continuous improvement into everything you do. And so again, I'll call out at Catalysis the site visits we have arranged this year. If you really want to improve your leadership skills and you really want to be better at understanding continuous improvement, sign up for one of those things because I guarantee you, we will show you what good looks like.
Yeah,
And then you can take that home and start to practice.
yeah. Um, Thank you. The thing that comes to mind for me is, and what I'll go back to is awareness is the first step in recovery. So it's when you go to site visits, because a lot of times people don't know what they don't know. And so when you go to stuff like that, then all of a sudden you realize what's possible, you know, and if you're wondering whether or not you're the one or your organization's the one that there's an opportunity, look at your KPIs, look at your dashboard, look at your patient outcomes, all the stuff that matters. Are you where you desire to be or should be? Are you doing the best work? Are you still leaving stuff on the table? Are you still people that are injured? Right. And if that's the case, check it out. Check it out. I agree. Thank you, thank you, thank you. So this has been Leadership Soundbites with Michele and John Toussaint. Until next time, please like, share, subscribe, and have a freaking awesome